I don't know why everybody's asking me, what can I do to lower glutamine? You cannot lower glutamine with a diet. Okay, can you tell me that? Can you report that back? Why people ask me, what do I need to? Hundreds of people, how do I lower glutamine? You need a drug. You need drugs to do that. And you have to strategically use the drugs. So you can lower glucose with diet. You cannot lower glutamine to the point to kill tumor cells with a diet. You cannot lower glutamine to kill tumor cells by diet. You need a drug, and that drug has to be pulsed. It cannot be chronically given because we need the glutamine for our immune system. We need the glutamine for the health of our gut. We need the glutamine for urea cycles. We need the glutamine. It's essential. But if we are too aggressive on glutamine, then we destroy our gut, prevent our immune system from functioning, and because our immune cells also need glutamine. So this is the press pulse therapeutic strategy for managing cancer. The paper is on open access. Anybody who wants to read the paper, please read the paper. The answers to your questions will be in the paper. Please read the paper. People say, oh, the cancer cells can use ketones. No, they can't. Show me the evidence of tumor cells using ketones in the absence of glucose and glutamine. I have never found it. Nobody's shown this yet. We interrogate these tumor cells. So people keep asking me, what diet? Well, he didn't say what to eat. Your job is to lower your glucose ketone index. And people say, well, how do I do that? You determine that. Some person can eat vegan. Some people can eat carnivore. Some pescatarian. Some Mediterranean. I don't know. Eat whatever you want to eat and see what it does to your GKI, glucose ketone index. And people say, well, I tried doing this. Well, don't eat anything. Just drink water and see if it goes down. Well, I don't know if I can do that. Well, then don't do that. Do whatever the hell you want to do. All I'm saying is you want to kill cancer cells, it's on your shoulders, right? Now, you can always choose to take radiation and chemo. I mean, we're not stopping you from doing that. I'm never saying anybody. I will never tell anybody, don't do a toxic poison or radiation. If that's what they would like to do, that's their prerogative to do that. But I'm saying that we can get we can get a handle on the growth of the tumor by just simply depriving it of the two fuels needed for driving the dysregulated cell growth. And those two fuels are replacing the energy that would get from oxidative phosphorylation using oxygen. Tumor cells take in oxygen, but they're not using it for energy. They're producing reactive oxygen species, ROS, which are causing the mutations in the nucleus. And damaging other parts. So tumor cells cannot use oxygen effectively to generate enough energy to drive dysregulated cell growth. They need fermentation. The fermentation is coming from substrate level phosphorylation in the cytoplasm with glucose as the fuel, and mitochondrial substrate level phosphorylation in the mitochondria with glutamine as the fuel through the glutaminolysis pathway or the glycolysis pathway. So lowering glucose restricts the availability of energy through the cytoplasmic glycolysis pathway. Lowering glutamine specifically, just on off, pulse. Hit off. How long should we go off? We're working on that. Just do a little bit here with the drug, the oxynorlucine, or maybe some parasite medications which seem to target glutamine, and then we take it off. God forbid we hurt the patient. We want no toxicity associated with the elimination of these tumor cells or tumor. We want the person to get gradually more and more healthy the longer we use press pulse metabolic therapy. So improved health, no hair loss, no gum bleeding, no diarrhea, no fatigue, no nausea, none of the stuff. You want the tumor to be strategically destroyed slowly while the rest of the body gets healthier and healthier by transitioning from glucose to ketones, and the energetic efficiency of the mitochondria in the normal cells will be significantly improved. Based on the Drenick study and based on these other studies that unfortunately so many people don't read or don't know about, and read our press pulse therapeutic strategy. That has the framework to do this. And then, well, it didn't go through the details. The paper that Dr. Durai, with our other 20 or so authors, has just come out putting flesh on the framework. That paper was just published for glioblastoma, but the same strategy would be effective for the majority of cancer. They're all very similar. They all can't, they're dependent on glucose and glutamine for fuel. They can't switch to other things. So lung cancer, colon cancer, breast cancer, they're all the same. Very similar. I don't want to say the exact same. They're all very, very similar and having a dependency on a fermentation rather than an oxidative phosphorylation. So this strategy that I've just mentioned should be quite effective. And when we see people who actually do it, not all of them, you're not going to get somebody who has in hospice with 3 days to live. When you're first diagnosed with cancer, you have a lot of many people already have, they're in pretty good shape. This is when we can push this down. And then, of course, if we do have some surviving cancer cells, despite what I've just said, then a small low dose of chemo or a small spot shot of radiation might finish off the few surviving tumor cells. Maybe a shot of immunotherapy, a Keytruda, Opdivo, CAR-T, doesn't make any difference. You're fighting now a very small number of cells that are just hanging on, barely hanging on for survival. And now you can come in with a part of the standard of care and finish them off. But the issue, of course, is we can take that angry, malignant tumor and bring it down into a less angry, less malignant growth, and then gradually hammer away at it. And in the end, we can either surgically debulk it, or we can hit it off with some small dose of chemo. You don't have to have your hair falling out and bleeding and all that crazy stuff. I mean, if you know strategic. Now the problem, what I'm talking about, is unfortunately not known, understood, or by the majority of people in the oncology field. They haven't been trained to know that cancer is a mitochondrial metabolic disorder and not a genetic disorder. Once you realize that, then what I'm talking about is based on hard science, replicable results, and understanding the biochemistry and biology of the tumor and how that differs from the biology and biochemistry of the normal cells in the body.